Okay, we are recording now. Assalamu alaikum everyone, and thank you for joining this ECG session. I hope it will be a good one for all the trainees and in fact even for some consultants. So thank you for Ahmed for coming up with these suggestions, Ahmed Traib, and thank you to Qazi Salim Ahmed and Nisar Shah for agreeing to do this talk. So I'll keep everyone mute. Salim bhai, if you want to unmute yourself. Or before doing that, Ahmed, do you want to say a quick word and introduce the two speakers? Ahmed, do you want to unmute yourself and give a brief intro of the two speakers?
Yeah. Dr. Qazi Salim Ahmed is a consultant cardiologist. He's my mentor. He's my teacher when I was working in Hull. Now he's working in Halifax. And Dr. Nisar Shah is a consultant cardiologist in City Hospital. Wonderful speakers, have deep insight in ECG. And I will give mic to Dr. Ahmed to start, please.
Dr. Qazi Salim Ahmed, please unmute yourself.
Salim bhai,
thank you very much.
Okay.
I will share the screen now. I think we can start straight away.
Ahmed, can you mute yourself? Qazi bhai, once you are ready to share, go ahead.
Okay. What is this coming up? Okay, so this is the ECG of 13-year-old boy.
Qazi bhai, 1 second. Can everyone see the full screen? Can people confirm?
Yes.
Okay,
Yes.
Thank you. Thank you. Mute yourself now. Qazi bhai, go ahead.
Okay, so this is the ECG of 13-year-old boy. So just look at the ECG and then we'll go to the next slide and to ask, what do you think? Can we go next?
So maybe give them just one more person is coming in now. So let's wait another minute. Let them have a look. And Abdul Hamid is asking live poll. Yes, there will be a live poll. Just give me a minute. So I think I'm going to launch the poll now. So people can answer the question. Once you've seen the ECG on your screens, please give us the answers. And you can start now. I will let you know once I've got enough answers. We've got 25 answers so far. Please keep going. A few more left. A few more people left. It's all anonymous. Even if you don't know, go for it. We'll stop this poll in next 5 seconds. 5, 4, 3. Okay, so poll is ending and I'm going to share the results. So can you all see the results in front of you?
Yeah, we can see them.
Okay.
Okay.
So you got an idea of what people are saying, Qazi bhai, yeah?
Yes.
Shall I leave the poll up there or just remove it now?
Just remove it, I think.
Okay, so 38 people saying sent to general cardiology, and second favorite answer is reassure and discharge.
So only 25% people said that you can reassure them and discharge.
Yeah. Okay, back to your screen.
So normal pediatric ECG findings. So this is very important to understand in a patient, young child. So what are the normal findings you can expect in an ECG before we actually label them completely abnormal or label them as having any genetic disorder? So heart rate over 100 beats per minute, rightward axis. You can see juvenile T-wave pattern in leads V1 to V3 with T-wave inversion. You can see dominant R wave in V1. There can be RSR pattern in V1. The young patients can have a significant or marked sinus arrhythmia. Because of slick AV node, they may have short PR interval, and the QRS duration can be less than 80 milliseconds. And there can be Q waves in inferior and left pectoral veins, left precordial leads, sorry. So you can see in this ECG, we have RSR pattern in V1. We can see deep T wave inversion in leads V1 to V3. We can see somewhat right axis shift as well. So all these findings are completely normal in a young boy. So obviously when the transition happens from childhood to adulthood, so you can see that these changes gradually tend to disappear as they enter into adult age.
So you can. What would have been your right answer out of those 4
The
questions?
right answer is that was the normal ECG.
So you would reassure and discharge them, yeah?
Reassure and discharge.
Okay, let's go to next one, unless someone has a burning question.
Any question? Yes.
It's an interactive session. So someone has mentioned, yeah, dominant R waves V2 and V3. Abdul Hamid has mentioned.
What's the mechanism behind the T-wave inversion V1 to V3 that changes into adulthood?
It's difficult to understand. I think it's possibly the right ventricle obviously was not working initially in the infancy, and as the babies grow and they are more actually active physically, the right ventricle is more active as compared to the left ventricle, or possibly it takes over. It's difficult to explain what happens.
Could it also be the heart's position relative to the body as the body grows bigger?
That might be contributory, obviously, as
Yeah.
well.
Okay, let's move on.
So this is case 2, 42-year-old father of 2, apparently fit and well. At the gym on the treadmill, he becomes dizzy and briefly loses consciousness, and he was brought in by ambulance.
Lima, we
This
can't
is
see
the-
the ECG.
This
Can we
is
see
the
the
ECG.
Can you all see the ECG?
No, I can't see.
Yes.
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 So maybe Ahmed, it's your screen.
Okay.
Are you on the phone, Ahmed, or are you by the computer?
Oh, it's fine. It's fine. I can see.
Got it. Okay, yeah, go ahead. So resting ECG is on the screen. Sorry, Qazi bhai, carry on.
Yes, now you can. So what is the diagnosis? You can put
I'll
the poll
launch the
on.
poll. I'll launch the poll. Yeah.
Can we,
No, don't write in the text message, Mohammed. Give us the answers here.
So what is the diagnosis? Right bundle branch block, focal. So diagnosis in terms of the for the patient, not the looking at the ECG. Can you tell me the diagnosis?
It's coming. People are voting. So 20 people have done it. Let's wait another 10 seconds before we close it. Yeah, 5 more seconds. 35 people have voted. Come on, guys. A few more. Okay, so stopped at 30. There you go. More people voted just now. I'm going to close in 3 seconds. 3, 2, 1. Okay, and this is what they've said, Qazi bhai.
So right bundle branch block, focal RVO-TVT. So that's very
So
good.
it's question between number 1 and 4 options. So most people have gone for ARVC, followed by right bundle branch block. Yeah.
Yes.
Some have gone for bifascicle block. So I'll stop sharing that, and now you can carry on with your comments.
So this was the ECG during tachycardia that was recorded. So as you can see in this tachycardia ECG, So look at the axis of axis during tachycardia. It's a downward axis, and it's a left bundle branch block pattern. So obviously the focus for this tachycardia is above in the basal area. So it's towards the outflow tract area. So it's a right ventricular outflow tract area. So this is RVOT VT. So what we see actually, what we had seen in the previous ECG, so you can see in this ECG, look at this. So that's the only one ectopic over here. If you look at this right bundle branch block morphology there, and look at V3. So these are epsilon waves.
Can you point to the epsilon wave once again?
So as you can see over here, this is another ECG of arrhythmogenic right ventricular cardiomyopathy. So this short blip soon after the QRS complex over here, as you can see these arrows. So these are epsilon waves. So these epsilon waves, these are just very small positive deflections that are buried within the QRS complex, appear soon after or within the QRS complex. So this is in fact due to post-excitation phenomena which happens in these patients who have got infiltrative disease, fatty, fibrofatty infiltration within the right ventricle, or it can be in the left ventricle as well. So because the scattered myocardial cells are myocytes, so they excite later on as compared to the rest of the myocardium. So that shows these epsilon waves appearing soon after the QRS complex. So as you can see over here, now look at this. So this is the small deflection soon after the QRS complex. That is the epsilon wave. So what we can see in patients with arrhythmogenic right ventricular dysplasia or cardiomyopathy. So in this ECG, although all of these features may not be present, the epsilon waves we only see in 30 to 40% of the patients. So we can see in this ECG, for example, you can see there is first degree AV block, PR interval is prolonged. And after this ventricular ectopic, there is a short sinus arrest. There are premature ventricular complexes, and we can see these epsilon waves in leads V1, V2, and V3. So these are very clear, V3, V2, V1. And these patients can have negative T wave or T wave inversion in chest leads. So any questions?
Let's go ahead. Qazi, next one. Maybe what we'll do at the end of your slides, we'll pause for 5 minutes for any further questions.
This is another ECG of arrhythmogenic right ventricular dysplasia or cardiomyopathy. So this is another case. It's 88-year-old patient with heart failure, presents with palpitations. So we can put the poll there.
So yeah, I'll just let them have a look at the ECG for another few seconds. When I put the poll up, does it actually hide the ECG or comes separately?
It is separately. They can move,
we can move it.
On
Yeah.
the
You can move it? Okay,
yeah.
that's fine. I just wanted to make sure. So I can put it up now then. So there you go. Okay, so you guys can move it around and have a look at the ECG at the same time. So we've got 20 responses. Let's get a few more, 10 seconds, and then we'll stop. We've got 53 in the audience. Now, if I take out the speakers and the panelists, which is, we can't vote, I can't vote, we should have at least 45 votes. So we've got 36 votes now, a few more to go. I'm going to stop in 5 seconds.
Yeah, the other thing is, as soon as they vote, this slide disappears. So then they can actually look at the ECG.
There you go. So can you see the results?
Yes.
So most people have gone for digitalis toxicity,
Mm-hmm.
and the rest have gone for hypocalcemia, and some people with hyperthyroidism. So tell us what the right answer is, then carry on.
So the right answer is digoxin toxicity.
Okay, so I'll stop sharing this. You can carry on now.
So what we see in patients with digoxin toxicity, so these patients can develop atrial tachycardia with variable block or any fixed block, whichever. And they can develop junctional bradycardia because the digoxin can actually block the AV node, and then they develop junctional bradycardia. And in patients with atrial fibrillation, the patients can go into complete AV block with atrial fibrillation. So that will be regularization of the atrial fibrillation. Normally, we don't expect at all that atrial fibrillation will be regular. So it has to be irregular, almost always. But if it is regular, so either this is due to complete AV block, or if patient is on digoxin or any other rate limiting medications, so that might have actually triggered the AV block. So patients can develop sinoatrial exit block as well with the digoxin. So in case of sinoatrial exit block, what happens? The sinus node has got the property of automaticity. So it generates impulses, but those impulses cannot enter into the atrium. So it does not exit the sinoatrial node. So the way you can identify the sinoatrial exit block from the sinus pause is, so you will see that the R to R interval during exit block will be exact multiple of the normal RR interval. So for example, if the first R to R interval in this case is, for example, if it is say 600 milliseconds, so if the next, at the time of block, it is exactly 1200 milliseconds, that means the sinus node actually fired, but unfortunately, the impulse did not enter the atrium, so was not able to come out of the sinus node. And finally, these patients with digoxin toxicity can have bidirectional ventricular tachycardia. That's what we saw in the previous ECG. So bidirectional ventricular tachycardia. So what happens in bidirectional ventricular tachycardia, we'll go through in the next slides. As you can see over here, so digoxin effect and toxicity, there is slight difference. So in case of digoxin effect, we do expect sloping depression of ST segment, and the most importantly, the T wave rises above the baseline. That's very important point. But while in case of digoxin toxicity, so T wave will not be above the baseline. So if you see a patient who, in which case the T wave does not cross the baseline, so it is either at the baseline or below the baseline, then patients can have digoxin toxicity. The sloping depression of ST segment can also be due to digoxin toxicity. So as you can see over here, this is digoxin effect. this very famous Salvador Dali moustache. So this is, as you can see over here, the ascending limb of ST segment, it rises above the baseline. So when it rises above the baseline, that is digoxin effect. When it does not rise or stay below the baseline, then it can be digoxin toxicity. So regularization of the atrial fibrillation. So patient, you can see, is completely regular rhythm, ventricular rhythm. So that means the digoxin is hitting the AV node harder, and that's why you get the rhythm coming from the AV node as an escape rhythm. When it comes to this bidirectional ventricular tachycardia, the differential diagnosis, so it can be digoxin toxicity, it can be catecholinergic polymorphic ventricular tachycardia, and this can also be seen in patients with dilated cardiomyopathy. The mechanism behind this bidirectional ventricular tachycardia is that tachycardia involves alternatively left anterior fascicle and left posterior fascicle. So as you can see, if you look at the V1, so both are actually right bundle branch block. But if you look at leads 1 and lead 3, the axis completely shifts from left to right. So when it is left anterior fascicle involved, axis will shift to the right. When it is left posterior fascicle involved, the axis will go to the left. So that is the bidirectional ventricular tachycardia. So it's another patient with dilated cardiomyopathy, similar bidirectional ventricular tachycardia. So if you flip this ECG clockwise, so you will see this Christmas tree sign. So we can go to the next question now. A 22-year-old college student complains of sore throat, fever, and chest pain. You can run the poll.
This time people are voting quicker. Okay, another 10 votes to go, then we'll stop the poll. Whoever is left, you can volunteer. We'll stop in 10 seconds. Quick question. Those who've joined from the mobile device, can you also vote?
Yes, Saki, we can.
Okay, thank you. I'm going to end the poll and share the results. So here we go, Kazibai.
Oh, that's brilliant.
90% have not
That's
thrombolized
brilliant.
the patient. Okay, I'll
So
stop.
this is pericarditis. So as you can see, what we expect, the changes in pericarditis. So ST segment elevation is either flat, not convex. Either it is flat or it is concave, as you can see over here. And most importantly, so look at the TP segment, which is downsloping. So they are off the baseline. So in fact, all these TP segments, they are running parallel to each other. So this is, if you extrapolate this TP segment, you will see there is PR depression and there is ST segment elevation. So opposite will happen in the lead AVR. So that is the whole, if you look at the TP segment. If the TP segment is flat, then pericarditis is unlikely. So this ECG sign of downsloping TP segment is called Spodek's sign. As you can see over here. So PR depression, ST segment elevation. So that is just simple extrapolation. So just extend this, extrapolate the TP line, PR depression and ST segment elevation. And opposite happens in the AVR. PR elevation and ST segment depression. So that's pericarditis. So another patient, 35-year-old male, presented with syncope. So recurrent episodes of syncope, 24-hour tape was normal. Admitted after episode of syncope and cardiac monitoring was done, and the symptoms that were recorded on the ECG are here. So we can run the poll now.
You know, when the poll results come in, it feels like it's a live election night. So I can see the results pouring in. 56% have voted. We're just waiting for the next. Someone said you can't see the slides, but other people can. So maybe log off and log in again.
They can't see the slide.
Only one person said that. I think most people.
I think they probably have very slow
Yeah,
internet
most.
I think when the Zoom opens, the window that opens is that the participants are shown. So if that window is minimized and the slide window is put up, then you will see the slides.
Yeah, so it depends on what you're looking at. Yeah. Okay, so we've received 80% votes. So I'm gonna end the poll and share the results. And can you see, Qazi-bhai?
Yes, dual chamber pacemaker implant.
Most people. Are you happy with that answer?
Yes, so we can see that. That's brilliant. So answer is correct. So what is the diagnosis then? So diagnosis in here, we can see very clearly there are P waves marching through and there is no QRS complex. So this patient has paroxysmal AV block. And if you look at this, how this actually started, so a simple ectopic set of this phenomena. So that is a ventricular ectopic in this case. So now look at this, the EP study of the same patient. So what we found on the EP study, so with each QRS complex, you can see there is an A wave before, there is his signal, and then QRS complex on the his catheter, and then AHV again, and same happens AHV, we can't see over here, and then another ectopic comes next to this, and we see that there is AHV, but after that we can see there is a signal appearing there. There is H signal appearing there. So the conduction crosses the AV node, reaches the His bundle, but does not pass on to the ventricle. So same happens with the next beat. So these are all P waves with A signal on the His catheter, A signal on the His catheter, and then H, which is the His bundle signal, but no QRS complex. So that means this is infrahisian block. So the block is at the level of Purkinje system. So what happens in these patients in paroxysmal AV block? So this is precipitated by atrial ectopics. It can be precipitated by ventricular ectopics with retrograde conduction, in which case the retrograde A wave actually will work as an ectopic for that to initiate this phenomena. So during block, like we see in complete AV block patients, the sinus rate shows increase, which is a simple compensatory phenomena. But during normal ECG, there will be one-to-one conduction and PR interval may be completely normal. So what happens in a normal Purkinje system, as you can see, so that's what happens. If you look at the action potential of normal His-Purkinje system and in a diseased His-Purkinje system, so that's what happens in the phase 4. So there is a spontaneous depolarization, and because of that spontaneous depolarization, it does not pass on to the myocytes. So if you look at the action potential, so it has got 4 phases, as everyone would know. So in paroxysmal AV block, one-to-one AV conduction suddenly changes to complete AV block. And this can occur following atrial ectopics, retrogradely conducted ventricular ectopics, or during Valsalva. And there is critical lengthening of PP interval followed by AV block. So that critical lengthening of PP interval, so it hits at the time when there is a depolarization occurring at the level of His-Purkinje system. So that spontaneous depolarization, which is you can say, it does not leave the Purkinje system itself, but stays within the Purkinje system, as that spontaneous depolarization is sub-threshold for the His-Purkinje system to leave the His-Purkinje system and enter into the myocytes. It does not cause QRS, generation of the QRS complex or ventricular depolarization. So P wave after atrial premature beats conducts via AV node into the His bundle and to the Purkinje system, where it finds that the cells are refractory due to local phase 4 depolarization. It can be phase 4 or phase 3. So it's a similar phenomena over here. You can see this atrial ectopics set off this phenomena, and the patient was lucky to have this escape rhythm. And similar phenomena over here, as you can see, this can be potentially life-threatening. So atrial ectopics started this phenomena and this long pause there. Another example of similar. So in this case, this atrial ectopic set off this phenomena.
Qazi, there's a quick question from Abdul Hamid that in your EP study, was AV block spontaneous or provoked?
It was not provoked. It was spontaneous. But this is what we do in syncope studies, obviously. So we can actually see this phenomena. If we see this phenomena with premature beats, then we can obviously make the diagnosis. The patient has got infranodal disease. So infranodal disease is class 1 indication for pacemaker. So another last patient. So this is 75-year-old Asian lady presented in the A&E with syncope. So this is just look at this, spend enough time, and then tell me what it is.
Do you want me to launch the poll question now, or that's for later?
Yes, you
Okay,
can. Yeah.
Okay, let me do it now. Yeah, we've received 50% constituency polls, another 50% left. 30% left now, 70% have voted. We'll finish in 5 seconds if you guys want to quickly cast your vote. In 3, 2.
This is a real, actually, this is a patient actually I saw 3-4 months ago in the hospital.
There you go, Kaji bhai.
Yeah, complete AV block 63% and 2 to 1 19% and something else 19%. So this is something else.
Okay.
So if you look at this, so look at this. These complexes are left bundle branch block. You can see in the V6 is left bundle branch block with left axis deviation, wide QRS complexes. And with this left bundle branch block, each left bundle branch block QRS complex has got 3 P waves. And then there is right bundle branch block here. You can see in the V1 is a right bundle branch block. And then each right bundle branch block also has got 3 P waves. So this is alternating left bundle branch block and right bundle branch block with each bundle having 3 to 1 block.
This was not an easy one, let's be honest.
So this was when the patient was transferred to in the CCU. So she was in 2 to 1. The left bundle started to conduct, and it was 2 to 1 AV block. So any questions?
Is this the end of it? Okay, that's the end of your talk. Okay. So do you want to stop sharing, Kaji bhai? And firstly, I think it was fantastic. I mean, 6 cases, but really, really good. Let me check in the chat box if there's any question left. Somebody mentioned from Sarosh Khan that in paroxysmal AV block, an escape rhythm can potentially potentiate the AV block, as the escape rhythm can cause P wave, retrograde P wave.
Say again, what was the question?
Sarosh, do you want to unmute and ask?
Yeah, sure. It's a fantastic talk. So in paroxysmal AV block, you said the actual AV block can be triggered by a retrograde P wave from a ventricular ectopic or an atrial ectopic. So if you get an escape rhythm, say a ventricular escape rhythm whilst you're in the AV block, does that potentiate the AV block in the sense that you'll always have retrograde conduction coming up the AV node, so they can always, what I'm trying to say is normally
the escape rhythm will actually take over. So
okay.
Escape rhythm can continue for any length of time until the sinus node will finally take over, and when the impulse will find a window into the Purkinje system when they are not in phase 4 depolarization. So when it finds, it will start to conduct normally.
Sure. Okay. Thank you.
Okay. Any other questions from anyone before we move to the next speaker? Fine. I assume there's no more questions. So in the interest of time, Kaji bhai, thank you so much. Salim bhai, if you want to mute yourself for now, and Nisar bhai, if you want to unmute. Nisar bhai, can you hear us?
Yeah.
Okay. You're ready to share your screen? Okay. If you want to go to full screen mode, please.
Are you able to see the screen and hear me?
So I can. Can other people confirm if they can hear and see clearly?
Yeah, we can.
Yeah, thank you.
So Nisar bhai, you give me a prompt when you want the poll question put up, and I'll do that.
Okay, I will do. Thank you very much, Saqib and Ahmed, to organize this. I have a confession to make. Dr. Ahmed is my mentor and teacher, so I don't have that depth of knowledge. I'll try my best to show you some interesting cases, and if any hard question comes my way, I'll deflect them to him. So I'll start off with, I will put up some ECGs for diagnosis, and then I'll highlight some management aspects. So some ECGs will be more so for management discussion. So first case, 42-year-old chap who has no known health problems, admitted with dizziness, and I'll show you his ECG next. I'll get you to have a look at it, and then we'll put the poll up for you to comment. Okay, there you go.
While they're polling, Nisaba, when people are polling, can you see the votes coming in or only me?
I don't see the votes coming in. I
Okay.
can see the polling screen.
Okay, that's fine. So 2/3 have come in. I'll just wait a few more seconds.
Yeah, okay.
Okay, another 5 seconds will close. We've got 42 votes so far. If other people want to cast their vote, and we are closing in 3, 2, 1, and there we go. So there are your results, Nisar bhai.
Okay, yeah, well done.
Nice mix.
So most of you, well, okay, all right. I see. So some of you think it's atrial flutter, and about similar numbers think it's the sinus bradycardia. So let's go to the ECG. Okay, so these are your sinus speeds. If you look at these ECG, and then you see ventricular ectopics, and that is electronic interference. And you then see this one junctional ectopic coming in with retrograde P wave. And the reason I think this is electronic interference, because you see clear sinus rhythm, for example, there, and you only hint of some bizarre rhythm type you're seeing is in lead 2 and 3. And the reason being that your lead 2 and 3, one of the electrodes is in the left foot, and that is the dodgy electrode here, because that's either has got loose connection or skin's not been prepped properly. So this is electronic interference, sinus bradycardia with ventricular ectopics.
Any
Okay.
questions on that one from anyone? Okay, let's move on.
Okay, we'll move on to next one. So 52-year-old chap was referred with history of palpitations with symptoms, and a 24 Holter was organized, and this is what it showed. So I'll give you a mag view in the next screen. You just want to quick look at this one for a few seconds. I'll then show you the next one before we put the poll up. Okay, so I've just magged up the important bit, and then I'll ask you a question next. Okay, there you go.
This is fun. I can see Biden ahead, then I can see Trump taking the lead, and then Biden goes ahead again. Yeah. So okay, we got 75% votes. I'll wait another 10 seconds. Another 5 seconds, then we'll close. Okay, closing now. So 53% think is AVRT, 27% go with VT, and 20% have gone with double tachycardia. Do tell us what that is, double tachycardia, by the way.
I will. Okay.
Are you happy with the answers? Or
I'm happy with the answer with the majority. I'll go
Okay.
with the majority.
fine, and then there you
And
go. Now you can explain.
so what you're seeing here is a broad complex tachycardia that then moves to narrow complex tachycardia. The broad complex is a bit slower, and it's when it gets narrow, it speeds up. The lower the number, faster it is in terms of milliseconds. Okay, and let's just move on. So double tachycardia, those who are going to be sitting in exams would hopefully be shown a device EGM because you can see a tachycardia on the atrial channel and the ventricular channel simultaneously going on, and that's a real term, and it's called double tachycardia. It is not a ventricular tachycardia; it is AVRT, and I explain that on the next slide. So what's happening here that you've got broad complex tachycardia to start off with on the main strip that I showed you, which is slightly slower, and that's because the left bundle is blocked and is conducting via the right bundle, and as it goes from the right to the left, the conduction is not slick because it's not using the normal conducting tissue. And as we know, myocyte conduction is slow, so it takes extra time. And it soon loses the left bundle activation, start to conduct through the left bundle. So you basically not conducting through cell to cell now, it gets faster and it gets extra 40 milliseconds. And so your broad complex moves to narrow complex that way. And if you see acceleration of a tachycardia with loss of the bundle without a pause, that means that tachycardia is using the bundle branch and is AVRT using the ipsilateral concealed accessory pathway. Okay, so I will, if there's no burning question, I'll move on to the next question, next case. Okay, so 2013, a 22-year-old woman got referred to cardiology clinic with palpitations while she was pregnant. Her ECG, which I'm going to show you next, was reported normal. She had an echocardiogram also that was reported normal. She was reassured and discharged. That was the ECG back in 2013 that was read normal. So just bear that in mind. So what happens next? 7 years on, that child unfortunately suffers cardiac arrest, but fortunately he survives and receives an ICD. Pediatric cardiologist now refers mother back to adult service for reassessment. And that is one of the ECGs of the mom now. So I'll get you to spend some time looking at it. And then I'll show you lead V1 and V6 next. And then next, I'm going to show you the slide we'll put the polls on. Okay, Saqib, if you could put the poll on.
Do you want to go back to the ECG while they're polling?
Yes, please.
Yeah, so they can look at the ECG. Yeah, thanks. There you go. Thanks. I think we'll allow a few more seconds. People are taking their time, but I think it deserves a bit more time. We got 75. We got 75%.
All right.
Results back. Okay, let's give another 5 seconds, shall we? Go on. If it's anonymous, 1 in 3 chance of getting it right. Whoever is left, just send something through.
I didn't put 4 or 5 options anyway.
That's fine. So you got 80%, and I'm going to stop here. And amongst the 80%, well, there's almost an equal split in the bottom 2 options. But
okay, well, at least half of you are still awake. Okay.
Okay. Well, are you happy with the majority here?
Yes.
Okay.
So this is a bidirectional VT. You've just been shown ECG by previous speaker. And if you look at these are sinus beats. And right bundle branch block mimicry and the left one. And when you see axis changing from right to the left, as Dr. Ahmed explained to you earlier, that is bidirectional VT. And one cause for bidirectional VT is CPVT, which is a autosomal dominant inherited condition. And patient can present with exercise-induced symptoms after with syncope or a cardiac arrest. Digoxin toxicity is relatively common, and however, if the patient presents with this toxicity-related arrhythmia, please try not to cardiovert because you can put them into resistant VF that you won't be able to get them out of. So the treatment for those patients is use of digibind and trying to stabilize with other means without attempting to shock them. And interestingly, an aconite is a plant which looks like this, and it's apparently only 20 to 40 mils of its juice is enough to kill people within 4 to 6 hours because it causes bidirectional VT. And there was a case report, a Chinese lady imported this, I think, bark of this plant to America, used it and got admitted in hospital, puzzled lots of people. Eventually, they worked out that it was this plant. And the rest of the causes, the list of causes for bidirectional VT these are relatively less common, but you could potentially see a case. Myocarditis, I think, would be something that I think that I may have seen a myocarditis, a fulminant myocarditis, when I didn't know much about bidirectional VT myself, and acute ischemia. So these are probably likely cases that you may see in your clinical lifetime. So for this lady, she's 29. She is first-degree relative of a cardiac arrest victim. She has depression and she can't do without them. She can't tolerate beta blockers. She feels lethargic. She's a smoker. She's an ex-rugby player. So what to do to protect her? And I don't think that you've got much other option but to offer a defibrillator. Okay, so if you don't have any question for this, I will move on to the next case. Okay, so 37-year-old man.
There's one comment or a question. Subcutaneous ICD for a young person, would you consider that?
Subcutaneous ICD, yes, that is something to consider. Ideally, what you need is a shock box. I don't personally have much experience with subcutaneous ICDs, but I think that she could be a potential candidate for it.
Okay, let's move on.
37-year-old man who is normally fit and well. Chest pain that lasted for a few days, 10 days ago, and now he presented with worsening breathlessness. And I'm going to show you ECG next. We're going to give you a short time for it. Have a look at this ECG and then we'll put the polls up. Okay, and polls are coming now.
Can you go back to the ECG?
Can you see the ECG now?
Yeah. For this one, the answers are coming quick. We got to almost 70%.
Pretty good.
Let's wait for the other ones to
Okay.
follow through.
That's what I would expect.
So I'm going to stop in 10 seconds. We got 85% votes. A few left if you want to cast your votes now. In 3, 2, and 1. Okay, so you got 75% going with pericardial effusion tamponade. Nisar bhai,
I will go with majority here.
with majority. Some are saying pulmonary embolism. Maybe guide them as to why it should not be pulmonary embolism here.
Yeah, so what we are asking based on the ECG, you've got the story and you've got ECG to look at, and then we're asking what would the ECG and the story point towards. It could be anything, but what would the ECG and the story would point towards? And what you're seeing on the ECG is electrical alternance. You're seeing QoS voltages changing, and that's because if you imagine the normal, if you're doing an ECG on a big person or a big lady, your RV voltages in the chest lead in particular might be relatively smaller compared to a very thin, skinny person where you get quite large voltages. And same mechanism apply because it's the distance between the myocardium and the recording electrodes that would dictate the QRS voltage in this case. So within, if the heart is sitting within the large sac of fluid and it's wobbling in and out with beat to beat changes, it's coming closer to the chest and moving away from, and that's how it changes the voltage, I think. And this is referred to as electrical alternance, a sign of pericardial effusion. Okay.
Okay, let's move on.
Right, next one, 73-year-old patient who is post-op day 5. They had mitral valve repair and tricuspid angioplasty ring was placed. A surgical SHO calls you, those who work in the tertiary center, that they've done an ECG because the patient was reporting dizziness. That looks a bit weird, they think, and they've asked you to kindly review the patient. And that's the ECG. So I'm going to show you the polls now. Okay.
It's still coming. It's taking time this time. 40% in. And I hope most people have joined from the computer, because then it's easier to look at the ECG than just a mobile device.
Mm.
Okay, so 75% in. We'll wait another 10 seconds. A few more than 10 people haven't voted. You've just try your luck. 5 seconds left. 3, 2, 1. Here we stop. So most people, as you can see, 87% have gone with AV Venkabak.
Well done.
A few percent. Are you happy?
Yep, very happy.
Okay.
Okay, and I'll just explain for those who think it's sinus arrhythmia and others. So if you look at this ECG, you see a pattern emerges. You're seeing here is group beating, or called a paired beats. And then if you look at this in a close-up, you start to look at this T wave that slightly look bizarre. This is another T wave. So these two T waves don't look similar. And you then look at this P wave. So this is, if you remember, this is a pure P wave, and this is the T wave with superimposed P wave. Now this is very broad. And first, I think the reason it's broad is because first half is T wave, then the next half is P wave. And if I then show you, so that is your PR interval, which is longer. This is where your P has not conducted. That's a blocked P wave. And then this is a next conducted P wave, which is shorter. Now, this is classical AV Venn-Quebec description, where you get the PR interval, which is longest before it drops, and the next conducted PR interval will be shortest. There are some atypical forms, but this is the original Venn-Quebec description that most people forget this bit, that way progressively PR interval prolongs and then drops. But what you must see also is the PR after the drop PV should be shortest. And that gives away the answer, being AV Venn-Quebec. Okay.
Okay, brilliant.
Right, so management. So post-op patient, so generally you try and avoid pacemaker in these patients, especially if there's no pre-existing conducting tissue disease prior to going into surgery. And if the conduction is improving by looking at the ECGs or their so most of them will be on epicardial pacing system, so seeing what the underneath rhythm is. Because those of you who pace, tricuspid endoloplasty rings can make lead placement challenging, and all sorts of complications, including infections, etc. So this particular patient is AV Venn-Quebec, unless you observe this getting into high grade AV block, and then you wouldn't pace, or you avoid pacing, or the AV block is improving. Again, it's a good sign that connection will recover, and they might avoid pacing. So, okay, next one, 61-year-old, previously fit and well, presents with sudden onset breathlessness and lethargy. Ambulance was called. You are asked to see them in recess, and their blood pressure is 100/70. They do not have pulmonary edema, but they look exhausted. And that is ECG. So the question is about managing them. So have a look at it, and then we'll just quickly move on to the questions.
Shall I put the polls up now while the ECG is there?
Yeah.
Okay, so if you go back to the, ECG, that's fine. So answers are coming in quickly. 75% received. Let's wait another few seconds. I think 10 people have not voted. All the others have. Okay, 5 more seconds. If you all want to just, this is your last poll anyway. This is the last case, so just wait a few more seconds. Just see if you can answer. Okay, I'll stop here. And let me share the results. So, can you see the results, Nisar bhai?
Yeah, well done.
Yeah,
So, majority
so-
of you cardiovert, and this is what I would advise.
Some have gone for amiodarone.
Yeah, so this is fast, broad, irregular tachycardia, and this is pre-excited atrial fibrillation. So as you wouldn't dare to mess with FBI in America, you shouldn't mess with FBI arrhythmia. And because so cardioversion is the best treatment for it, I'm going to go on to the next slide and explain to you why. So this is what happens after you cardiovert them. You can see pre-excited ECG here with possibly right-sided accessory pathway. So what determines problems with the pre-excited tachycardias is what is their effective refractory period of the accessory pathway. And if the effective refractory period is less than 250 milliseconds, they can conduct very fast. So less than 1% of patients with pre-excitation can end up with ventricular fibrillation if they go into atrial arrhythmias, atrial fibrillation. And so if you give them amiodarone bolus, for example, which is can be a vasodilator, and with the increased sympathetic drive ongoing, you can accelerate tachycardia and make hemodynamic instability much worse. Therefore, DC cardioversion is the best course of action, in my view.
One question is, if the patient is stable, it's come in the chat box, can IV flecainide be used if they are stable?
Well, I think the IV flecainide is again is going to be a high risk strategy unless you're confident in your diagnosis. A person is young, you do not have underlying structural heart disease. I think there's lots of things that you need to think about before you give them IV flecainide. With that rate, I think you're better off with DC cardioversion or probably amiodarone if you were to give a drug therapy, and if they are stable. With that degree of tachycardia, I think you're asking for trouble by trying to treat them with medications.
Thank you very much.
Okay, is there anything else? Do you want to stop sharing your slides, Nisar bhai? I think that's done with your slide, is that correct?
I've got one case, but that doesn't have questions, but I'll leave
Okay,
it.
go ahead. No, go ahead then, go ahead. Finish your case.
So I'll just quickly show you this one. This is a 51-year-old patient who had syncope, was referred by medics to Fast Fit Clinic as well as to cardiology clinic, as they would do. And when you take history, it appears that he's a taxi driver, and he had an argument with his customer. Police was called, and police witnessed that his vision suddenly went, and patient's own memory is that he woke up in ambulance handcuffed, and police described witnessing a tonic-clonic seizure. His bloods on the day he arrived in A&E were normal. And when you dig deeper, he tells you that his brother died of a heart attack, aged 33, but he doesn't know much about him apart from this. That is an ECG. That looks pretty much okay, it's blameless with that story. QT interval borderline, but you know there's nothing much there on that ECG, I think. Now, a Holter was put on, and if you look at the Holter, you see this notching in the T wave. Notching in the T wave is highly abnormal and suggestive of long QT problem. You wouldn't be measuring your QT here, but rather here. And when you do that, the QT interval is around 592 milliseconds. And when you look at the QT, long QT criteria, so his QT is longer than 480. He scores 3 points there. He's got notched T waves, 1 point. And he had syncope when he was in a stressful situation. And if we don't definitely know his brother's story. It could potentially be, so at age 33, cardiac, it's a myocardial infarction, it's a 50-50 chance, probably less. So he scores quite a bit. And if you score 4 or more, it is long QT syndrome. So if you do diagnose them with long QT, you obviously informed the patient about the diagnosis, inform the GP and neurologist of the diagnosis, and you start them on beta blockers. So Nedolol is the common beta blocker that you start them on. Occasionally, some patients may go on to propranolol. A couple of years ago, there was a shortage of Nedolol supply, and people being switched to propranolol. And review them as soon as if there's a further syncope, because you might be then discussing with AP colleagues, potentially thinking about ICD. For screening to all first-degree relatives, and refer for genetic testing. And that's all from me.
Thank you very much. If you can stop sharing the slides. Thank you, Nisar bhai. First of all, brilliant session from both of you. Any questions from the audience or any other consultants who are on the panel? Any comments from anybody? Please unmute. Feel free now.
Hi, it's Omar. Thank you very much for excellent talk. I just have a quick question, if possible, about the last case. Since he's already, this chap with long QT has already had a syncopal event, is he not offered an ICD straight away rather than trying beta blockers first? Thank you.
Yeah, I think he obviously he was not on treatment, and so if you want to be 100% certain, you could put them on beta blocker and put them on treadmill to see if they shorten their QT interval, and then if they don't, or they had another syncopal event, you will offer them ICD. Approach may vary a little, but I think that was untreated. So if you put them on beta blockers, treat them, and then reassess. That would be my approach.
Thank you.
There's one more question come through that in your last case, or case number 6, how to diagnose pre-excitation on a 12-lead ECG with VT. So any tips for that?
This was not VT. There was irregular broad complex tachycardia. So this was pre-excited atrial fibrillation. But if you're not sure, you treat that as VT. If patient is borderline hemodynamics, very fast heart rate, I would cardiovert. Hence, I did say that a lot of people in this group may be ST3 and might not be confident enough at 3 a.m. to make that judgment call. You don't want to lose the patient. You can always argue what was best afterwards, day next, or look at ECG diagnosis. For safety reasons, what I've been taught and what I would advise to all my junior friends to cardiovert these patients. You are not going to save electricity bill for NHS if you don't. You might lose your patient.
Thank you, Nisar bhai. Qazi bhai, back to you. Any comments from you, as you were the mentor and the tutor, as Nisar bhai said?
Yeah, no, I'm fine. I think this long QT patient, I would add, this is long QT 2 syndrome, because there's a bifid T wave there. These patients are usually, they get triggered arrhythmias early after depolarization, which sets off torsades and which can potentially degenerate into ventricular fibrillation. And that trigger for them is usually auditory type of triggers. So these patients, once we score them according to their scoring criteria, as Nisar has mentioned, they should ideally be offered the ICD in addition to the treatment. The ICD is for prevention, the beta blocker is for prevention of torsades, but does not actually prevent sudden cardiac death.
2 people have asked a similar question. Why Nadolol or Propranolol? Why not Bisoprolol? Is there a reason not to choose it? Any of you 2 can answer that.
I think Nadolol is commonly used. I'm not exactly sure what would be electrophysiologist's preference, but I've personally seen Nedelol being used as in vast majority of patients. I don't know whether Dr. Ahmed has any comment to make on this.
I think potentially anti-adrenergic effect is probably more in these with these specific beta blockers.
Okay, I have to admit I've never used or seen my colleagues using it, but yeah, it's good to know. Okay, there are no more questions on the chat box. So thank you to both of you. Ahmed, I'll come to you in 1 second. Just to give you a heads up, there'll be some more sessions coming up. I hope you all have enjoyed. There is a session that Ahmed has kindly organized with Abdul Hamid. He's online. We'll give you a taster of that. Very quickly before that, I don't know, is Suhail online? Suhail, are you here or not?
Yes, I am.
You are? Okay, so just very quickly, because you've also planned another intervention session and you've taken a good lead on that. And that session is coming up soon as well. Do you want to just
That's right. Well, we're hoping to run it one evening next week. So we've got 3 great cases with a focus on left main stem. So hopefully we'll put the poster out later at some stage over the weekend. So yeah, okay. Absolutely.
I think you joined later as well, but I think the interactive tool worked very well. People were interacting with live poll, so we can use that for that session. Going back to you then, Ahmed, your comments, and then you want to introduce the final Dr. Hamid, who can briefly give a taster of what he will do.
It's a really wonderful session. I really congratulate Salim Bhai and Nisar Bhai to present a wonderful ECG. It's a great point of learning for everyone. We are arranging some more sessions and need a feedback from everyone. One session is about right heart cath, which is traditionally weak, all of us. Abdul Hamid is a consultant cardiologist and pulmonary hypertension specialist at Sheffield Hospital. He will deliver this session somewhere in December. And then there is another news that Dr. Isma Rafiq is agreed to deliver one session on adult congenital heart disease in first week of January. This is likely the common emergencies in adult congenital heart disease, and some talk on the pregnancy as well. These are the sessions. We need feedback. First question is that what's the frequency of these sessions? We should go for fortnightly or monthly. Then the second is what's the frequency of ECG sessions? Saqib, can we raise some poll for it?
Yeah, I'm coming.
Yeah.
First,
I think so. We can give to Abdul Hamid. He can deliver a taster presentation about the right heart cath, and then we can deliver a poll.
Let me do this now quickly. I've set the question up. There you go. So all the audience.
I think it needs to be a separate question about ECG teaching versus the specialist.
Yeah, this is just an overall one that, will it be too much to do so soon, or how frequently should these be?
In my opinion, ECG teaching is really wonderful, actually.
I'm just glad no one is clicking on daily. I've actually said please no. Okay, almost everyone has voted. It's, you know what? This is Biden versus Trump. 48% and 49%. So most people have gone for once a month, actually. Some are saying twice a month. Once a month is more easily doable. Twice a month can be done, but then you have to do 24 sessions in a year. You don't want to run out of steam as well. So that's my thought. I've not voted. I would have voted for once a month, but anyway. Sorry, I forgot to share the results. There you go. These are the results. Okay, so once a month it is by 1 vote. Okay, over to Abdul Hamid, shall we? A quick taster of what he wants to do probably in December.
Thanks, thank you. And Qazi Bhai and Nisa, thank you very much. Really well presented. And it's really the discussion after each case, just so that's where the learning is. Otherwise, you can do too many cases and not learn, but that's really good. Thank you very much. So Ahmed, thank you for asking me. So I was going to do a talk on right heart catheterization, and I can just show you a brief slide if that's okay, because that's what I was asked to maybe stimulate interest. So, so what we'll do is when we do the right heart catheterization talk, so I'm a consultant cardiologist in heart failure and PH, but I have moved now to PH. So it's something that's obviously not, you don't do it as often, therefore the learning is not the same. And when you don't do things regularly, then you don't fully get to grips with it. And we all forget things, you know, we'll forget stuff about ECG. For me, it was a reminder of some interesting facts today. So what I learned in my talk is just the pulmonary circulation pathophysiology, how to do rights and plus or minus lefts when you need to do it, what data is required and how to use that information. What are the caveats to doing the measurements, particularly the wedge pressure, and a lot of nice cases to illustrate that. Just briefly, I mean, what the systemic circulation, you know, the left ventricle pump basically generates sufficient force to maintain a mean aortic pressure of around 80 or 70, and your aortic pressure is 120/80, and your RA pressure down here is like 5. So the pressure difference from the aorta down to the right atrium is 75. The cardiac output, just say on average, is 5 liters. So your resistance is about 1200 dynes, okay? Whereas the pulmonary circulation is different. The right ventricle is thin-walled, generates sufficient force to maintain a mean PA pressure of around 15. So normally your PA pressure is low, 25/10. And then the left atrial pressure should be less than 10, you know, as low as possible. And then, but for the same amount of blood going through the lungs as it goes around the aorta, the pulmonary vascular resistance is a fraction of that in the systemic circulation. And so you always have to ask yourself, well, why is that? And that's because the pulmonary circulation is, you know, low pressure, low resistance, can increase flow, and it's because it's very compliant and distensible. So the surface area of the lungs is like quoted to be like the area of a tennis court, yet it's all compacted within the thoracic cage. Obviously, this is marvelous in terms of, if you think about the origin of humans and creation. So a testament to that. And so, but you know, when you do right heart cath, we'll talk a little bit about what you can do. You can measure pressures, you can measure flow, oxygen saturations, you can do provocative maneuvers to unmask certain diseases or demonstrate certain responses. So that's just a little taste about what right heart catheterization is. I don't want to show any more. It's hopefully to stimulate interest.
Good idea to keep the suspense going. So that's fine. I think we'll do the intervention one with Suhail hopefully next week, and then in December plan a date with Abdul Hamid. Thank you for that. And then probably once a month going forward. Also the trainees, feel free to participate. You know, you've got good cases to present. If you're planning to present in any conference, you want to use this platform as a trial run, yeah, feel free. We can give you a grilling before you speak to another learned audience. This is your platform. And then similarly, when for intervention cases, come up with your cases, volunteer to present. I think use and abuse this platform as much as you can. Finally, we'll probably email the ones who I've got email addresses for. I'll send a Google document to get a feedback, so that everyone, when they present, they get a feedback. And some have asked whether they'll get a certificate of today's attendance. I think what we'll do these days, you just need to put it on your CPD diary, but that's more for consultants. But yeah, I don't mind sending a confirmation by email and saying that you guys attended, or draft a certificate. That just adds to my admin work, but we can do that certainly. If that helps you all. So that's all from me. Anyone else has to say anything? I just want to thank you all first of all. Any trainees, please unmute if you want to say something.
Thank you very much, Saqib bhai. Absolutely fantastic.
Okay,
thank you very much.
Thanks, Sarosh. Should we call it a day? Salim bhai, Nasar bhai, Ahmed, if you're happy.
Absolutely.
Thank you very much. Thank you.
Okay, so look out for Suhail's poster for next week's one of the weekdays. Not this week, I think the week after, maybe in the evening. In intervention cases on left main stem.
Thank you.
Thank you, everyone. Allah Hafiz.
Allah Hafiz.
Allah Hafiz.
Don't forget to stop recording.
That's what I'm trying to do. I'm just my computer had paused for a moment.